by Dr. Barton, Retrochiasmal and higher cortical visual dysfunctions.
Anyway, I could have shortened the talk title for you because I'm only going to talk about higher cortical visual dysfunctions. Not really enough time to talk about the geniculate and the radiation, because most of that's fairly simple in terms of the kind of visual field defects that you're going to see with them primarily. What perhaps is more difficult and more intellectually interesting, for me anyway, is what happens when you get beyond the striate cortex. Most of you ophthalmologists? No? No one was too late to raise hands, I guess. But if you're a neurologist, you're probably quite familiar with some of the issues that I'm going to be talking about. For ophthalmologists, maybe you don't think about this too often, so it's good for you to stay here and listen to this. Because these can be the source of some very intriguing, interesting, and fascinating visual complaints that you're going to hear from patients. So we're going to begin this talk after striate cortex, because after striate cortex, which is also we sometimes call V1, is where information starts to fan out into a parallel distributed hierarchy, a specialized cortical areas. And these areas, they're different from V1. You know, in V1, you can, if you know that your strokes in the striate cortex, you can predict from the shape of your scotoma exactly what part of your calcarine cortex has been taken the hit, because the retinotopic representation is so fine there. But within that scotoma, it doesn't really matter what you're showing, whether it's a color thing or a moving thing, all vision is gone in that hole. That's not true when you get beyond striate cortex. When you get beyond striate cortex, the information doesn't really care so much about where in the retina the light is falling. It's more to do with what exactly specific type of visual stimulation is occurring. Now we can group these into two streams, which I'm going to use for this talk, a ventral stream and a dorsal stream. In the ventral stream, also kind of called the wet stream, it's the object identification areas. And this has to do with things like process color perception, form processing, which is also important for recognizing what objects you're seeing, and particular kinds of objects like faces and words are some of the pragmatic examples of problems that arise if you have a lesion in this stream. The dorsal stream is different. This is the occipital-parietal stream. That's illustrated more over here by these yellow areas here. This is the where stream, preparation for action. If you have a lesion here, you're going to affect processes like motion perception, stereopsis, spatial localization, which is important if you're trying to figure out where to move your eyes or how to grab something. And that's a very kind of different sort of defect than you see here, and they're going to give rise to very different symptoms. But if you're paying attention to what the patient's saying, you will be able to kind of figure out where the problems are coming from. So if you have lesions of those functions, this is what you're going to end up with. If you have a ventral lesion, the kind of defects you might
see are achromatopsia, general visual object agnosia, or selective agnosia, such as pyrrhexia, which we talked a bit in reading, prospagnosia, or topographic nausea. So prospagnosia is probably how we'll recognize the cases that should be to you.
Topographic nausea is where you are having trouble lost in familiar
surroundings.
The dorsal stream here, if you have lesions there, it kind of helps with problems with impaired perception, which is really a problem of visual attention, as well as multimodal problems with somatic and attention modalities, but we usually test for it with vision. Astereopsis, which is a loss of three-dimensional perception, and then balance syndrome, which is a triad of simultanic nausea, oculomotor apraxia, and optic ataxia. I'm not going to talk about all of these necessarily. I certainly want to talk about hemineglect because that's a huge field all of its own. But some of these others we'll touch on briefly to give you a feel for what might these sound like, what kind of lesions cause them, and how you might test for them. Okay, so let's start with the ventral stream. And the very first thing, the sort of intermediate level thing, is color perception problems. If you have a cortically mediated loss of color perception, we can call this achromatopsia, acquired achromatopsia. People who have this complain bitterly that their vision is now, they experience vision as shades of gray. And it's also often got a dirty tinge to it. It's unpleasant. It's kind of like watching TV, but black and white TV, but even worse than that. This chromatopsia is a partial defect where there's color distortions, things look faded or washed out. So there's some residual color perception, but it's not what it used to be. Hemiachromatopsia is where the color vision loss is limited to one hemifield. And that's kind of interesting because we don't often look for that. And it's often asymptomatic, which means that if it's asymptomatic and we don't look for it, we're probably missing a lot of this. One of the things I would tell you about is that if you see somebody who has a superior quadratic defect, check color in the lower field, because that's where you're going to see it. Now, one of the key clinical points here is that you've got to make sure that when you think someone's got a color perception deficit, that you don't have a color naming problem. Okay, that's different. It is possible to have a color anomia problem where you have trouble remembering the name for the word, for the color red, but you can actually still tell red from green. So if you test these people with sorting colors, they can sort colors into the correct hue arrangement, and they know that what the correct colors for objects are, that the sky should be blue. They can pick out the right color for that, but they just can't tell you it's called blue. Okay, that's different from an achromatopsic who has a lot of difficulty sorting colors and may not be able to kind of take the color crayons and color in the drawings correctly. Now, for achromatopsia, the pathogenesis of this is related to damage to a human homologue of area V4A or area V8 in monkeys. And where that amounts to in human beings is the lingual and posterior fusiform gyrus. And I'll show you an example of that later. How do you test for this? Now, the first thing you could try to do is color naming. I just told you that's not necessarily a good thing to do, but nevertheless, many patients with achromatopsia do have problems naming colors as well as sorting them, but that's not true of everybody. If you have partial dyschromatopsia, you may still be able to come up with very broad color names, very easily, like red, green, and blue. That's not a great test. That's a very, very large swath of the color spectrum can be subsumed under the name of red, but there's a lot of different reds. So that's maybe not the best thing. Pseudo-isochromatic plates, like the Ishihara plates, we have those all readily at hand in the clinics. But there's some little caveats there. If you hold the plate far enough away from the person so that all the little white spaces between the dots kind of merge and lose them, these subjects with achromatopsia may still be able to read the number. And that's because many of these subjects still have the ability to detect the boundaries, color boundaries. So they can tell that there's a boundary here around this one that makes that a 1. They just can't tell you what the color is inside and what the color is outside. Okay, so a little caveat there. Color sorting is the best. And what you're asking here is to for example, here, taking these hues, giving them these chips, and asking them to sort them into the correct arrangement like this. This they have immense difficulty doing. Classic test for this would be the FM100 hue test, or the D15. That tests hue sorting. You can also have versions that do saturation sorting. One of the interesting things, so that's 2 different dimensions of color space. The third dimension, which is lightness, can tell light gray from dark gray. They can do that. So brightness is often, and lightness judgments are often spared, but hue and saturation are the things that are going to be really messed up in achromatopsia. So to give you an example, this was a 74-year-old woman I saw in my Boston days. She noticed visual loss while at the circus with a granddaughter. By the time she reached the emergency room, she realized it was the right side of her vision. And when I saw her, she had a right superior quadrant myopia. So like I just told you, everybody I see with an upper quadrant defect, I test color in the bottom one. Now, that's not easy to do because most of the tests for color we have aren't made for looking in your peripheral vision, certainly not the Ishihara plates. So a simple thing you can do at the bedside, take 2 different colors like the red and green caps of your eye drops, hold one above the other, make sure that they haven't seen it until you put it into the field that you think's got a problem, and ask them which one's the red one, the top one or the bottom one. They'll usually kind of look at you and wonder, well, I'm not sure. And then if you move it across, as soon as you hit the vertical meridian, they'll go, oh, it's the top one. If they can do that, and that change comes to the vertical meridian, you know they've got a hemiachromatopsia on that side. So, and here's her lesion in the lingual and posterior fusiform gyrus. That's a classic location for achromatopsia. If you have it only on one side, that's hemiachromatopsia. To have real full-blown achromatopsia, you need to have bilateral lesions. No exceptions. 2.
General visual object agnosia. This is the inability to recognize the identity of visual objects with which you have previous experience. To qualify as a visual object agnosia, it should be modality specific. In other words, that if you show them a bell, they don't know what it is. As soon as you ring it, they know what it is because they can hear it. So it's modality specific. It's just vision, it's not auditory. If it's multimodality, it could be more of a semantic problem. It's also more than just anomia, right? It's not that they just can't come up with a name bell. They also, if you ask them, well, what does it do? Where might you find this? They can't put it together because they can't recognize it. They cannot therefore access correct semantic information to answer those kinds of questions. Okay. There are some subtypes of agnosia. One, and these go back maybe a century, I suppose. There's aperceptive and associative broad subtypes. For aperceptive agnosia, the idea is that they cannot see the objects well enough, they cannot get enough accurate perceptual data to characterize the shape of the object, therefore they can't recognize it. And the classic problem with this is with carbon monoxide poisoning. Classic patient was described in the 40s by Elizabeth Adler in Boston with the Coconut Grove fire with carbon monoxide poisoning in one woman who was then also studied about 50 years later again. Associative agnosia is a kind of an interesting version where now the perceptual processing seems to be intact to be able to get in the right form. So you ask them to sort rectangles and stuff, they can seem to do that all right. But what they can't do is take that information about the way the object looks and match it to knowledge they should have about the object. And that could be one of two forms. One is knowledge about how objects look. That's what we call structural descriptions. So they can see it accurately, but they can't access the information about what objects should look like. Or they have a problem with knowing what objects are used for, or what the semantic connections of these objects are. Therefore, they know that this sort of looks like a spade, but they can't come up with the word spade because that's a semantic association. It's a linguistic link to associate the name. They wouldn't be able to tell you how you use it to dig the earth. That's semantic knowledge. So you could either disconnect that information, so you have that information, but you just can't get the perceptual information to connect with it, or you might actually lose that. And the classic diseases that you will encounter these are often with posterior variants of Alzheimer's disease. And here's a classic example. This was a 62-year-old woman I saw who had 1 year of progressive trouble reading words, searching for items at her home, and stumbling on objects while she was walking because she didn't really recognize that they were there or what they were. For the last 6 months, she really found it very difficult to identify money. When she was trying to phone, she couldn't phone because she didn't recognize the numbers anymore. And in her photo albums, she didn't know who was who. So she had problems recognizing faces, numbers, reading, everything. Her ophthalmologist only knows the right hand myopia at that point. Was able to document the acute 20/20, interestingly enough. When you see her MRI scan, you can see she's got a lot of, this is a T2 scan, so things that are white are fluid. And there's a lot of fluid around these sulci back here, so she's got very generous sulci in the back part of her brain. This is posterior cortical atrophy, a variant of Alzheimer's. Here's what she did when we presented her with some line drawings. What is this? It's a snake. This was grass with a baby bird, and this thing here was a cookie. Again, she's just guessing. She's seeing some little fragments trying to make a guess on it. She obviously got the grass here somehow. I don't know where the bird is, though. I won't spend too much time on this. We talked about this already today. Global versus spelling alexia, the idea that it can be either disconnection or a word from agnosia. Here's a word from area again. Here's the sort of template drawings of two pictures we have this. You can see again the main damage is in the back here. Probably it's fusiform gyrus plus or minus the white matter here if it's a disconnection syndrome. Prosopagnosia. Some of those of you who do know me know I spent my professional life in the lab looking at a large part of it looking at face recognition. But I won't give you more than a few slides on prosopagnosia here. This is the loss of the ability to recognize previously familiar faces. And I can't think of another disorder that's more fascinating than that. And when I hear a patient with prosopagnosia, it tells me that he comes up to a mirror, waves at it, and then figures out that's a reflection. That's pretty weird. It's a great story. Now that doesn't mean that they can't recognize people at all. Okay, sometimes they can recognize
faces by distinctive features. If there's a funny glasses that you center wear, or you got a peculiar facial scar or a mustache, they can recognize that. But that's not recognizing your face. That's recognizing some local kind of weird distortion you have. But they can also recognize people by other visual cues. Gait is a very prominent one. I have had several patients tell me that they can't recognize who you are when you're talking to them, but as soon as you turn away and walk away from them, they can tell who you are. Voices, they should be able to recognize voices again because this is a visual specific deficit. What is the basis for prosopagnosia? There's really two competing ideas, and I think the grounds are still open for both of these. One is that you actually do have face-specific processing in your brain, and that's damage to this face-specific processing that causes prosopagnosia. And the fusiform face area, which was first identified by Nancy Kanwisher, in the inferior portion of the occipital lobe, is a likely candidate for a face-specific cortical module. Others suggest that it's not really just about faces. It's just because with faces, we're asking you to do something very, very refined and subtle in terms of just object recognition. And that most of our faces look very, very similar when you think about it. You know, we all have a nose and two eyes and a mouth, and it's all about the same place. It's only very subtle variations in that shape that make one face different from another. And that's not something you're usually asked to do with other objects. But if you push that with other objects, maybe you would find that you have a similar deficit. So it's more of a problem with expert judgments, you know, at a very high level degree of object differentiation that's being asked and being damaged in this situation. And some of the evidence for this is that in some prosopagnosis anyway, if you ask them to do such a high level, like for example, if you have a patient who happens to be a bird expert, it turns out that they also have trouble recognizing birds that they were able to do before their stroke. So, just as with general object agnosia, there's apperceptive and associative forms. The apperceptive forms, there's an inability to see the precise spatial structure of the face. So if you have these 6 faces, which we call the twins test, all of them have been subtly modified and different from each other. I won't make you feel embarrassed about it, but the eyes are moved closer together here. The mouth is moved higher up here. The mouth is moved bigger here. The chin is moved more narrow here, and the forehead is higher here. And I think once I pointed those out to you, you can recognize them. For the prosopagnosia who has apperceptive deficits, even after I point them out, they can't tell the difference. You can also tell them with face matching, which of these 3 faces is different versus the other. That's the kind of test that these apperceptive prosopagnosis cannot do. They just can't see the difference between faces. They all look alike to them. The localization of this defect is in the occipital temporal lobe, right about here. This region, as it turns out, is where the fusiform face area tends to lie. The occipital face area is down here. In the social prosopagnosia, though, that's not the problem. These subjects can match faces. They can see the difference between faces. Okay, they know which ones are different, but they still don't know who it is. And the idea here is that the perceptual processing is intact to a point, but when you then need to bring what you're seeing to what you know, then they have the problem. So they have a loss of or disconnection of perceptual processing from facial memories. Now, in the past, we used to kind of diagnose this by saying perception looks okay, so it must be associative. But now, one of the ways we do this is we index it with tests of imagery. And a test of imagery is such where you don't need to use perception. I'm not showing you a face. All I'm doing is saying, don't look at anything, close your eyes, think of 2 people, Stuart and Martha Stewart. Which of them has a bigger nose? So you have to go into your head, find the face memory, no perceptual processing, and answer the question. And if you don't have those facial memories anymore, you can't answer the question. And the classic location for this lesion is in the anterior temporal lobe, here in this subject with bilateral lesions from herpes encephalitis. Topographic nausea. This is the inability to orient in familiar surroundings, and like all complex skills, you actually have a number of processes that you could use or may need to use to navigate correctly. So there's several variants. One variant is a place agnosia, where you've lost the memory for buildings and landmarks. And most of us do use buildings and landmarks to orient in space.
Around, you know, that comes to this building, you turn left. But you can't recognize a building anymore. You have to know how to do that. So that's probably, that commonly accompanies prosopagnosia, and the reason for that is because we see on fMRI that there's a parapicocapal place area right next to the fusiform face area. So if you lesion that, you've lost your ability to recognize landmarks. Loss of self-orientation in space gives you problems with route planning and finding, and this is often more with parietal lesions where you have trouble kind of figuring out how to, situate yourself in an environment in which way you better go. Another kind of unique thing that we've been looking at recently is failure of cognitive map formation and use. That is, if you've got the skills to orient yourself and you've got the ability to recognize places, but you can't put them together in a map in your brain, inside your mind. So you can't use a mental map based function, which is the most flexible and efficient way to figure out how to get to places in a familiar environment. If you're just following a simple route that you memorize, once you get off the route, you're gone, you're lost. Right? But if you've got a mental map, it doesn't matter, you're flexible. You know where you are on the map, so you can just figure out how to get back to where you want to be. But these subjects don't have this. The way we test this is we have a virtual environment that we prompt the subjects in, virtual landmarks. We have them memorize where the location of these landmarks, and when we put them back in it, and we ask them to try to get from point A to point B and see how quickly they solve it. If you have topographic nausea because you don't have a cognitive map, you can't do that. And you tend to have lesions in these sorts of places, either the hippocampal areas here or in the retrospinal cortex. Okay, so that's the word for ventral cortex stream. Now the dorsal stream. This is something completely different. It's not about object, place, recognition.
It's about space and time. And the first thing, just as with color perception being the intermediate level deficit in the ventral stream, the intermediate level deficit in the dorsal stream is motion perception. It's usually with bilateral lesions. There's only 2 known cases, so it's very rare. You're probably not going to see this. I haven't. Patient LM complained that objects jumped rather than moved, and falling water appeared to be frozen. She had trouble judging the approach to cars. Made going out to the streets kind of exciting. Unilateral forms do exist, but these are usually asymptomatic, and you can only pull them out with experimental tests. I won't spend too much time on this because there isn't really a clinical test you can do for this. You do need to have sort of experimental paradigms, computerized ones, which test interpretive aspects like integrating motion across noise, trying to see form defined by differences in motion, that kind of thing. It's a bit more complicated. Simple, just can you see moving back and forth, it's not a problem, even for bilateral lesions. The location is in the lateral occipitotemporal areas, out in the cortex here, whereas most of what we saw before was on the inside. This is on the outside here, and this is a classic location of somebody who's going to have an echinotopsic deficit. In this case, it's unilateral, so it's only hemiechinotopsia. Last thing I want to touch on is balance syndrome. This you will see. If you hang around, I usually see about 2 or 3 of these a year, at least. And there's a triad of 3 main elements. Each of them is dissociable from the other, so you don't have to have all 3 things, but often you do. The very first thing is simultanic nausea, which is defined as the inability to perceive more than one object at a time, or the inability to interpret complex multi-element scenes. Part of it's spatial, in that you have trouble maintaining distributed spatial attention, so there's a bunch of things going on, you only see one thing, the other thing is not apparent. This can be almost as bad as being blind. Because functionally, they have trouble navigating cluttered environments because they don't see everything. But it's not just spatial. Sometimes the interesting things are, if you hold 2 things up, like say you hold up your watch, you say, what's that? That's a watch. Hold your finger up, that's a finger. You go, now what am I holding up? Same spot, they see only the finger, only the watch, they don't see the other one. That's the inability to perceive more than one object at a time. It's an attentional deficit. Optic ataxia, this is difficulty reaching under visual guidance, despite the fact that everything else in your arm seems to be intact. And that's one of the key things. It's hard to diagnose if they've also got hemiparesis. It's related to a spatial disorientation because they have trouble judging position and distance of objects. One of the interesting things is that even though they have trouble reaching for things, because they can't figure out exactly where it is, because they do have intact object recognition, they may actually be able to form the grasp correctly for the object. Oculomotor apraxia is sort of an eye movement equivalent of this in some ways. They have difficulty initiating voluntary saccades, and they also have inaccurate saccadic targeting. So when they're trying to make an eye movement of something, even though they have intact visual fields, their saccades are not accurate. They have to hunt for things. And once they get there, they often also don't stay there properly. How do you test for this? Simultanic nausea, we usually give them some sort of picture like this cookie theft picture, where it's got lots of things going on, and you ask them to tell you what you see. Someone with balance syndrome will kind of randomly pick on something like, say, the chair falling, and that's all they'll see. And there's a chair. And everything else, nothing. Optic ataxia, you want to look at how they reach to visual and proprioceptive targets with the right hand versus the left hand, the right versus left hemisphere. On occasion, you will find that it really is just a visual reaching, so that when they're trying to reach for your hand, they're inaccurate. When they're trying to reach for their knee, they're fine. But as Gordon Holmes showed many, many years ago, sometimes it's a multimodal thing too. And reaching to anything is a problem. Oculomotor apraxia, this is a little bit more tricky, probably best done with eye movement recordings, but you may be able to show that they have almost like a spasm of fixation, that they take a long time to initiate volitional saccades, where spontaneous saccades look fine. To get balance syndrome, you do need bilateral parietal lesions. Unilateral ones can cause a contralateral optic ataxia, but most of the time it's a bilateral lesion you're going to see. And it's all about networks that are involved with attention, reaching, and saccades. These aren't exactly overlapping, so for simultaneous, the lesions are actually a little bit more posterior than the lesions for optic ataxia. That's why you can sometimes get dissociations. Here's an example. This is a 48-year-old woman. She had 4 days of headache, complaining of blurry vision and trouble walking. She had a left inferior quadrantanopia and a bit of hemi-neglect, but she had a lot of misreaching, inaccurate saccades, and she had simultanic nausea. And here are her bilateral posterior lesions up to the parietal lobe, down into the occipital lobe down here, and she had a cerebral vasculitis. So, to summarize, extrastriate lesions don't tend to cause field defects. There can be field defects, but they're usually due to damage to either striate cortex or the optic radiations around the very same area. But the extrastriate damage itself doesn't cause a field defect, but problems with specific stimuli. And what specific problem you have depends upon which extrastriate module you have. In the ventral stream, these are the symptoms of color perception or form perception, and in the dorsal stream, it's motion perception or visual spatial properties. And I'll end there.
Thank you, Dr. Barton, for this excellent talk.